Welcome. Thank you all for joining us today. I'm Sarah DeFeo, Chief Program Officer at OCRA, and I want to welcome you. We're so glad you're here. As of this morning, we have more than 2,600 participants registered for this important seminar, which is amazing. So we're going to jump right in, but first, just a quick review of our agenda today. We're going to start with some introductions and then hear from several patients who will offer their perspective and experiences. Then we'll move right into our presentations with Dr. Norquist and Dr. Liu, and we'll have some time for Q&A after those presentations. Please just follow the instructions on your screen to submit the questions. And you can feel free to add questions as the presentation is going on or send them through at the start of the Q&A session. So now we're going to have a few words of welcome from the President and CEO of OCRA and from our sponsor, AstraZeneca.
Thank you all for being here today for this timely and vital seminar presented by Ovarian Cancer Research Alliance and made possible by our generous sponsor, AstraZeneca. I'm Audra Moran, and it is truly a privilege to lead this extraordinary organization as its president and CEO. Your presence today underscores our shared commitment to use knowledge to improve lives for ovarian and all gynecologic cancers. For those of you who may not be familiar with OCRA, we are the largest organization in the world dedicated to fighting ovarian and related gynecologic cancers. Our mission encompasses a broad range of activities which can include convening experts and stakeholders to drive progress, advocating for increased federal funding, awarding critical research grants, and supporting individuals and families impacted by any type of gynecologic cancer. Last year, we were particularly proud to have awarded the most research funding in our history, $9.2 million, and expect to fund an additional $6 million this year. This means we'll have invested $128 million in ovarian cancer research and have been instrumental in securing $3.8 billion in federal research and education funding. Each year, we serve and support over 95,000 people through our education and support programs. Today's seminar is designed to provide you with essential insights into the complex world of genetic mutations and biomarkers and their critical roles in the treatment of ovarian, endometrial, and related gynecologic cancers. We have an exceptional lineup of expert speakers who will guide you through a range of important topics, which could potentially help you and your medical team with treatment decisions. Our topics are designed to help navigate the treatment landscape with a better understanding of things like targeted therapies, the difference between genetic mutations and biomarker-specific treatments and their importance in treatment decisions. We'll delve into the latest data on PARP inhibitors and discuss recent changes and their indications for gynecologic cancer, along with their implications for current treatment options, and we'll cover the differences between advanced and maintenance therapies and their respective benefits. Beyond providing in-depth information, this seminar is an opportunity for you to engage directly with our experts. We encourage you to ask questions and seek clarification on the various treatment options and recent medical developments we'll be discussing today. Again, we thank AstraZeneca for making this seminar possible. Our goal is to ensure you have the most current and accurate information so that you are empowered to navigate your treatment with confidence. We hope you find today's meeting provides you with a space where you can learn and connect. Thanks again for joining us, and we look forward to providing you with valuable information to help you through treatment and beyond.
Hello, I'm Rula Kakish, and I am the U.S. Medical Affairs Head of Women's Cancer at AstraZeneca. On behalf of AstraZeneca, we are excited to partner with the Ovarian Cancer Research Alliance in bringing this educational seminar to helping you hopefully understand the role of genetics and biomarkers in ovarian cancer. This is a very important topic to us at AstraZeneca, as we believe in the role of genetics and biomarkers in helping us better personalize cancer care. On my career in oncology, I've had the pleasure and the privilege to work on so many amazing new medicines that were targeted therapies. And these help deliver incredible results for patients. At AstraZeneca, we are following the science, and we want to understand how we can better help meet those complexities of discovering, delivering, and developing therapies that can be life-changing for as many patients as possible. We believe in our ambition to help eliminate cancer as a cause of death, but we also know we can't do this alone. Partnering with organizations such as Ovarian Cancer Research Alliance allows us to continue to better understand how we can serve patients on their journeys with their loved ones. And opportunities such as this one today, education that we hope you will find helpful to you and to your loved ones, so you can learn more about patient stories who have graciously agreed to share with us today, along with our expert panel who will hopefully share information you'll find useful and can take back to your healthcare professional and ask as many questions as you like. We hope you enjoyed today's educational session, and we are very grateful for you tuning in. Enjoy.
Now we're going to hear from three amazing ovarian cancer survivors: Helen Palmquist from Illinois, Louise O'Farrell from Florida, and Kathy Noble-Dutton from Pennsylvania.
Hi, everyone. My name is Helen Palmquist. I live in the northern suburbs of Chicago. My father was the youngest of 9 children. I am the youngest of 19 first cousins, many who have had cancer. I was aware I was at risk for breast cancer because my paternal grandmother, Rosa, who you see in this photo, passed away from breast cancer when my dad was 3 years old. Rosa had an identical twin sister, Fanny, and Fanny also died of breast cancer when she was very young. My dad, Herman, died of pancreatic cancer when I was 36 years old. I had no idea that, too, increased my risk of cancer. I was shocked when I was diagnosed with high-grade serous ovarian cancer stage 3C when I was 41 years old in 1987. I had no idea my diagnosis was connected to my father's cancer because the BRCA1 and BRCA2 mutations weren't discovered until the mid-1990s. How I learned about genetic mutations is not typical for today's standards. I had just finished a 3-month checkup with my gynecologic oncologist in 1997, and I went to use a nearby restroom. When I closed the door, I saw a flyer taped to the back of the door, and it invited ovarian cancer patients of Ashkenazi Jewish descent to enroll in a genetic study. I told my gynecologic oncologist I was interested, and I then saw a genetic counselor. My blood was sent to a Dr. Narad in Toronto, Canada. It took months to get the results, but I did learn that I was positive for the BRCA2 mutation. As I waited for my own results, my brother was diagnosed with early stage prostate cancer. And he found out before I did that we both have the BRCA2 mutation. This is my family tree. My Aunt Carolyn died of ovarian cancer. Her daughter, also named Helen, is an ovarian cancer survivor. And Helen, like me, tested positive for the BRCA2 mutation. Helen's son, Ronald, tested positive for the mutation. Ronald has a son, Jonathan, and Jonathan tested positive for the BRCA1 mutation. That's because Ronald's wife, Jonathan's mother, has the BRCA1 mutation. Jonathan and his wife, understanding the risk to their children, had embryos made and tested prior to proceeding with pregnancy. And now they have 2 small children that they know do not have the BRCA mutation. My Aunt Frida passed away from breast cancer. Her daughter Jean passed away from pancreatic cancer. Jean's son, Jack, passed away from pancreatic cancer. Jack had tested positive for the BRCA2 mutation. Jack's son, Ben, has the BRCA2 mutation. Ben and his wife had their embryos tested, and they have a little girl they know does not have the BRCA mutation. And Frida's other daughter, Amelia, lived to be almost 100, never had cancer. Amelia had 2 sons, Michael and David. They both tested positive for the BRCA mutation. David passed away from pancreatic cancer. Uncle Louis lived to be in his upper 80s and never had cancer. Uncle Louis's daughter, Joanne, passed away from breast cancer. And Joanne's daughter, Sally, has the BRCA2 mutation. When you look at all the sea of red in this family tree, you see how this BRCA mutation has affected my family. My son Brian tested negative. My son John tested positive for the BRCA2 mutation. In this photo, you see 9 brothers and sisters. My dad is in the upper right-hand corner. My dad's brothers and sisters came to this country as children, one by one. They left Germany, went across the Atlantic Ocean between the years of 1891 and 1911. Could speak no English. They had name tags pinned to their coats with their name and their destination, Colville, Washington. They were headed to their aunt, their mother's twin sister, Fanny. This photo was taken in 1963. It was the only time in their lifetime that all 9 brothers and sisters were together. My dad is in the upper right-hand corner. I always knew that my family had a remarkable story, but it became more remarkable once the BRCA mutations were discovered. This last photo was taken in 1987. It was a first cousins reunion. I'm in the lower left. This was just 2 months after my 7-hour debulking surgery. I was in treatment with chemotherapy. I was very sick, but I was determined to get to the reunion. Genetic mutations occur in 20% of those diagnosed with ovarian cancer. The genetic counselor I saw in 1998 told me that my sons, when they were old enough, should get tested for the BRCA2 mutation. I was also told that my sons should start getting tested for the PSA test, the test for prostate cancer, when they're 40 rather than 50. I would not have known to pass this information on to my sons if I had not seen a genetic counselor. My son John went to a urologist. He let the doctor know that he had inherited the BRCA2 mutation from his mother, who was diagnosed and treated for advanced ovarian cancer. The doctor replied to my son, a urologist, he replied to my son, "You don't have to worry, you're not going to get ovarian cancer." Between 1987 and 1994, I had 2 big surgeries and 2.5 years of chemotherapy. I got ovarian cancer because I inherited the BRCA2 mutation, but I may have survived ovarian cancer because I have the BRCA2 mutation. I responded well to a year of cisplatin, and for recurrence, a year of carboplatin. They say that those, especially with the BRCA2 mutation, often respond well to the platinum drugs. I am at high risk for breast and pancreatic cancer. For the past 17 years, I've been in Dr. Olapati's study at the University of Chicago, where I get 2 breast MRIs a year, along with an annual mammogram. I also get an annual pancreatic MRI. Like ovarian cancer, there is no early detection test for pancreatic cancer. So I feel I am being proactive by getting this annual test. Please help educate doctors and patients and their family members about genetic testing. Genetic counseling needs to be provided so people understand their risks. We need to educate them about preventative measures to avoid these cancers, as well as additional screening to catch these cancers sooner. Thank you.
Hi, I'm Louise O'Farrell, and I just turned 60 years old last month. I'm married and I have 2 adult sons. I also have chronic ovarian cancer and have gone through treatment 3 times since 2015 when I was first diagnosed. My subtype is high-grade epithelial ovarian cancer with a mixed histology. So what that means is that my cancer presented with components of both clear cell and endometrioid. At the time of my diagnosis, I had genetic testing done, and it showed not BRCA positive. So I went through that whole frontline treatment, and afterwards, I was NED for about 2 years before I recurred in 2018. And that first reoccurrence was pretty uneventful. And in 2019, after that first reoccurrence, I was NED again. So like a lot of survivors, I try to keep up on all the new treatment options. And one big change in the world of ovarian cancer at that time was the approval of PARP inhibitors, and they were being used as maintenance. And while I didn't fit the actual profile for a PARP, my gynecologic oncologist agreed that it might work. And I took it, Lynparza, for 6 weeks before I decided that those side effects were just too much. And I was told that they were going to decrease after about 8 weeks, but since we didn't know if I was really going to benefit from these drugs, I stopped them. Another advancement around this time was the use of genomic and biomarker testing to test for DNA abnormalities. And my doctor and I both agreed that this would probably help me in the future in knowing what treatments were going to be best for me. Insurance covers testing now, but it didn't back then. I had to pay $5,800 out of pocket, but it was worth it. My testing showed that some gene mutations and alterations were there, and it also showed, I think, 12 variants of unknown significance. I had about 15 pages worth of information on well over 300 genes. And when I first looked at the report, I was overwhelmed. And when I actually sat down to read it, it was really written in layman's terms and I understood it. So I was able to get a lot out of it. Each of my genomic and biomarker abnormalities were written out on pages with potential treatments, about frequency of reoccurrences, and about my prognosis. And then at the end, there was a findings summary, which was really helpful. And I also had about a page of clinical trials that at the time I would be a fit for. One of the most notable findings, though, was that I was HRD positive and that I was going to benefit from that PARP inhibitor, Lynparza, that I had tried before but stopped after 6 weeks. I also learned that the monoclonal antibody drug Avastin was going to be helpful for me. So with this new information, I knew that we would be going forward with Lynparza and Avastin next time. And I told myself I wasn't going to quit. I did reoccur again, and that was in 2021. And this time Avastin was added to my chemo. And then I went into my maintenance treatment afterwards with Avastin for 6 months and with Lynparza for 2 years. And yeah, I did have those same side effects, but I stuck with it. Unfortunately, after about 1.5 years, my bone marrow was suffering from toxicity on my blood work, and I had to stop Lynparza. But I'm hopeful that I got some benefits out of it. So I've been in remission again now for 2 years, and I actually just spoke with the company that did my biomarker testing in 2020, and I'm having that report recurated. I'm not sure if there's going to be any new treatments available for me next time, but I am excited to see that updated report. If you can have biomarker testing done, you need to do it. Knowledge is power.
Hi, everyone. My name is Kathy Noble Dutton. I am in the greater Philadelphia area. I am a licensed clinical social worker and a personal trainer. I have a business where I am working with people who are in process of being diagnosed or survivorship related to cancer. I myself am a survivor of endometrial cancer and I have Lynch syndrome. My story starts with my parents. My parents were both diagnosed with colon cancer when they were in their 50s, about 18 months apart from each other. At that time, there was no testing for Lynch syndrome, so neither one of them was tested. My mother had a second diagnosis of colon cancer when she was in her 70s, about 20 years after that. At that time, they did know about Lynch syndrome, and a genetic counselor met with her and recommended that she have genetic testing. My father never had another occurrence of cancer, and he was never tested for any genetic abnormalities. My mom tested positive for Lynch, and at that time, she and her genetic counselor strongly encouraged myself and my brothers to get tested for Lynch. I don't know why my brothers didn't. I can't speak for them, but I don't believe that they have ever been tested. And I did not test. I did not test because I was self-employed and have been for years. And I was very concerned at that time that if I ever needed to get health insurance when I was no longer covered by my husband for some reason, that I would be denied health insurance if they knew that I had Lynch syndrome. So my approach was let my doctors know, make sure that I get surveillance that I need to have. I started having sigmoidoscopies and colonoscopies in my 30s, and also let my gynecologist know about my mom's diagnosis. And I felt like I had myself pretty covered. And I actually honestly felt like most of the time I thought I was going to have colon cancer, never really thought too much about endometrial cancer. In 2013, I was diagnosed with endometrial cancer, and that was found through a routine pap smear. And at that point in time, I started interviewing oncologists, and my oncologist immediately said, "Is there any history of cancer in your family?" And I, of course, said yes. And then he said, "Was anybody ever tested for any kind of genetic issue?" And I said, "Oh my gosh, my mom has Lynch syndrome." I will tell you, I don't know why, but I really completely spaced out that she had Lynch, and don't know where that went in my head. And I'm a pretty savvy medical person, but it was not in the forefront of my mind. So of course my oncologist said right away, "We need to get you tested." And I tested positive for the same genetic variant, MLH1, that my mom had. I had a complete hysterectomy and I had treatment after that. And then it was recommended to me that my children get tested. I have 2 kids, a boy and a girl. And at that time, they were in their early 20s. They were both tested. One tested positive, one tested negative. And it was my daughter that tested positive. And at that time, she was 22. And the genetic counselor said, "We recommend that you have a hysterectomy as soon as possible. Have your kids as quickly as you can. Have a hysterectomy as soon as possible after that," to a 22-year-old girl. And she was floored. And we had to try to figure out what were the best approaches for her. The recommendations for people when they're young is to have endometrial biopsies, ultrasounds, colonoscopies, and all of those things that I did not have to deal with when I was in my childbearing years. By the time I found out I had cancer, I had already had my kids. So having the hysterectomy was not as big a deal as it would be for a young person. Those kinds of surveillance things are a real challenge for young people. That it's not something that's on the radar for most of their their contemporary peers, and it's hard for them to talk about it with their people their age, and have to be describing things that most kids are not dealing with. And they also have to be vigilant, and that is important and not always easy when you're young. So the winding road of genetic cancer, genetic testing, and surveillance continues into the next generation, and that is one of the things that is really tough to handle for people. And I don't think that it's an easy thing. I think it's a winding, not straight road for all of us. And it is, even though I'm very healthcare savvy, I missed it too. And I think it's really important. The more we get this information out, the more we learn from each other. I want to thank these three amazing women for sharing their experiences with us. And now we're going to move on to our expert presentations. First, we'll hear from Dr. Barbara Norquist, who will talk to us about the basics of genetics and biomarker testing. Dr. Norquist is a board-certified gynecologic oncologist, an associate professor at the University of Washington in Seattle. She is the Associate Chair of Research for the Department of OBGYN and also the Medical Director of the Breast and Ovarian Cancer Prevention Program. So I'm going to turn it over to Dr. Norquist for her talk, and then we'll do some Q&A.
Hi, I'm Barbara Norquist. I'm a gynecologic oncologist at the University of Washington in Seattle, and I take care of patients who have ovarian cancer and those who are at risk for it due to inherited risk. And the purpose of this talk is to review genetics and biomarkers kind of at the 101 level to help you understand what tests your physician might be ordering in order to better take care of your cancer. I'll start with going through some definitions of these terms. So the term genetics refers to the study of genes and heredity. So essentially things that you inherit from your parents and other relatives. Biomarkers are a measurable substance within an individual whose presence may indicate a condition. And biomarkers are very common in oncology because we use them to determine a whole host of different factors. The kind of best known biomarker in ovarian cancer is CA-125, which is a protein that can be measured in the blood that is most often elevated in patients with ovarian cancer, but not always. And I'll just mention too that no biomarker is perfectly predictive or sensitive, but we tend to use them as additional data points to help determine how to treat a patient and to treat their cancer. So inherited gene mutations can be a biomarker for risk of cancer. We can use certain biopsy findings and tumor markers to assist with making a diagnosis. We can look at various biomarkers for prognostic factors. And we can use them to predict response to specific therapies with findings like homologous recombination deficiency, folate receptor alpha testing, and various tumor mutations. We can use tumor markers to monitor response and also for detection of recurrence. So the NCCN guidelines for the management of ovarian cancer specify that patients with ovarian cancer, fallopian tube cancer, or primary peritoneal cancer should have a genetic risk evaluation and germline and somatic testing. And kind of for the purposes of this overview, whenever I say ovarian cancer, what I mean is the combined ovarian, fallopian tube cancer, and primary peritoneal cancer. So first, a few more definitions. So what exactly are germline and somatic genetic testing? So the term germline refers to changes that are inherited in your genome and are present in every cell of your body. So to check for this, we will collect lymphocytes either out of your blood, a cheek swab, or spitting into a tube in order to look for these inherited mutations. Somatic testing refers to testing the tumor itself, typically requiring a biopsy, although there's some newer techniques with obtaining tumor DNA from circulating blood. But the most common way at this point is from a tissue sample from a biopsy. And these indicate mutations that are acquired in the tumor. So again, germline, every cell in your body, and somatic, just the cells within a tissue or a tumor. The reason why we speak so much about inherited risk in patients with ovarian cancer is because inherited risk is incredibly common in patients with ovarian cancer, with around 20% of patients having a detectable inherited mutation in a gene that predisposes to ovarian cancer risk. This is one of the highest proportions of any solid tumor. And these changes have serious implications for both the patient with the cancer, because it helps predict response to various therapies, but also to their family, because various family members are also at risk of inheriting that same mutation. So say a patient is found to have one of these inherited mutations. What does that mean for your family? This is a genetic pedigree kind of showing, parents and descendants on the next line. And you can see if this is the patient who has a BRCA1 mutation, each of their first-degree relatives would be recommended to have genetic testing because they would each have a 50% chance of carrying that same mutation. If a family member is determined to have one of these mutations in BRCA1 or 2, what are the risks of developing ovarian cancer or breast cancer in that circumstance? And this chart here shows the risks of both breast and ovarian cancer for patients with BRCA1 and 2 mutations. And you can see that those risks are quite high. For breast cancer, it's around 75% by age 80. And for ovarian cancer, an up to 44% risk for BRCA1 and a 17% risk for BRCA2 up to age 80. And we have highly effective screening and risk-reducing surgery options for patients that can effectively prevent or detect early these cancers. And just a brief overview of how one inherits a mutation. So these cancer risk predisposing mutations tend to be what's called autosomal dominant, meaning you only need one copy to make you at risk for cancer. And say in this scenario, this is the mom and a dad and a kid. Each parent has 2 copies of chromosome 17, and on one of those copies is this inherited mutation. The child would then have a 50-50 chance of getting that abnormal chromosome from their parent. So either of those scenarios. What genetic testing options are available? You may hear some of these terms. I'll just define them for you. One is called single site testing, which is where if the specific mutation is known in your family, then genetic testing can find just that change in the genome. There's also Ashkenazi Jewish 3-site testing, which is sometimes called multi-site testing. And this is to look for the 3 common founder mutations that are present in the Ashkenazi population. Single gene testing refers to just sequencing a single gene, and gene panel testing is looking at multiple genes at once. This is by far the most common testing option available currently, but I'll show you kind of a historical timeline of when these other methods were used more frequently. So how does a person go about being tested? Kind of first things first is to just check in with your oncologist. It's typically a part of the standard workup for ovarian cancer is to get genetic testing. But if you have not had this in the past or have family members that you think could benefit from testing, here's a website to help find a genetic counselor, or one can speak with their medical team. So what does having one of these inherited mutations in an ovarian cancer predisposition gene, what does this mean for the patient who already has cancer? So BRCA1 and 2 and those other genes I mentioned as well are all part of the DNA repair pathway. Tumors with defective BRCA1 and 2 have a hard time repairing their DNA, which can lead to the cancer itself, but also makes that cancer more susceptible to certain therapies, just regular chemotherapy at large, but also a specific class of drugs called PARP inhibitors. PARP inhibitors specifically target alternate DNA repair pathways so that in a tumor with a BRCA1 or 2 mutation or some other defect in genome repair, when you combine that with the PARP inhibitor, that makes a kind of potent combination to treat those cancer cells. We've seen this in a variety of clinical trials, which I believe will be discussed in a different talk today, but just to kind of show some of the magnitude of these treatments. This is the SOLO-1 study looking at adding maintenance olaparib after primary treatment. These are patients with ovarian cancer who have BRCA1 and 2 mutations. And this blue line on the top are the patients who got olaparib, and the bottom line is placebo. And essentially the distance between those two curves shows you how much the patients getting the olaparib are benefiting. And in this study, there was a 70% lower risk of cancer progression or death. And this has been seen in a variety of other studies as well in the recurrent setting. And again, you can see all the spaces between the two lines of each of those curves, again, indicating that patients who have BRCA mutations respond well to PARP inhibitors. And then also want to make sure and mention that we feel that these inherited DNA repair mutations present either in the germline or in the tumor are equally predictive of response to these agents. One question we get sometimes is, I had genetic testing many years ago that was negative. Should I get this repeated when have different advances happened? And so I often will refer myself back to this timeline. If someone thinks they had genetic testing prior to 1996, they didn't, because that's when it became commercially available. Dr. Mary Claire King discovered BRCA1 in 1990. And then there's a big international race to determine the sequences of both BRCA1 and BRCA2. And then that eventually happened in the mid-90s. And the gene sequences were patented from about 1996 until 2013. So there was just one company doing testing at that time, and that was just BRCA1 and 2 testing. And then in 2013, gene patents were ruled unconstitutional. And then there was an explosion of multiple companies offering genetic testing. And at that point, the panel testing or next generation sequencing for many genes at once became standard. So most patients who had a genetic test after 2013 had a big panel of genes. And before that, you would have to refer back, but most had just BRCA1 and 2. So there could, depending on what year you had testing, there could be benefits to repeating. And when in doubt, you can speak with a genetic counselor or with your oncology team. Getting more specifically into biomarker testing within the tumor, this is most typically done from either a surgical specimen or from a biopsy, although there are some liquid biopsy techniques that are becoming more advanced, and that could play a bigger role in the future. But for now, most of these tests are done from a biopsy or a surgical specimen. First, you can do sequencing of the tumor, looking for, again, acquired mutations in DNA repair genes like BRCA1 and 2, or those other homologous recombination genes that I mentioned previously. And those changes help predict response to PARP inhibitors. Homologous recombination deficiency is another thing that can be tested for on sequencing, and that again predicts response to PARP inhibitors. And the next slide, I'll go into more detail on how we actually test for that. Protein overexpression is typically done on slides taken from the tumor, where we stain for specific proteins to see if they're present in more abundance than we would expect, which is called overexpression, and that can indicate a potential target for specific drugs. And finally, microsatellite instability can also be tested for using a sequencing approach, and that can help predict response to immunotherapy. So now I'll kind of go through exactly what homologous recombination deficiency is, because that's another very common biomarker that we're looking for in ovarian cancer. So there's a variety of things that cause homologous recombination deficiency. So mutations in BRCA1 and 2, either inherited or in the tumor, inherited and somatic mutations in these other DNA repair genes, epigenetic changes such as methylation to silence the function of the gene. So there's a variety of things that can lead to this, this phenotype. And then what you actually measure when you're doing a test for this is the effect of the homologous recombination deficiency, because that defective DNA repair tends to leave what are called scars in the genome that you can detect. And essentially that just indicates that at some point this tumor had homologous recombination deficiency. It's unfortunately not like a real-time test, because really we're just looking for the past scars. So I tend to think of this as like graffiti. We know HRD was there. We don't know if the artist is still present, but you can see that it happened at some point. The commercial HRD assays are based on allelic imbalance, which are the different copies of genes, and again is an indirect marker of DNA repair capacity. And in the circles there, it just shows the assays that were used in various studies, kind of linking PARP inhibitors to response to homologous recombination deficiency. Another fairly common question that comes up clinically is, I had tumor sequencing or tumor testing at the time of my initial diagnosis. Now that I have a recurrence, should I have another test on the tumor? And at this point in 2024, it's most likely to be expensive and probably not particularly helpful. Most of the time, insurance will only sort of cover one big genetic test of the tumor. And major drivers like BRCA mutations, homologous recombination deficiency, microsatellite instability, those features don't tend to change on recurrence because they're really intrinsic features of the tumor. Some exceptions to this are research studies trying to predict responses to therapy, and clinical trials or specific drug eligibility based on testing. But oftentimes you can go back to the archived initial tumor and run whatever specific test needs to be done from that. It's honestly fairly rare to need a new biopsy. I mentioned earlier a biomarker called protein expression. So this is looking for specific stains for proteins that might be present in particular abundance within a tumor. And this can be used to predict responses to targeted therapies. And a kind of newer method of targeting is something called the antibody drug conjugate. And essentially what that does is they make a specific antibody to that protein that's overexpressed, and that antibody is attached to a specific drug that can then, once it binds to those cancer cells that have the overexpressed protein, it can deliver the medication kind of directly to the tumor cells. This is an advancement in technology in treating all cancers, but becoming increasingly important in ovarian cancer. And I think you'll be seeing more and more clinical trials and hopefully drug approvals of these therapies. This is the slide is just a picture of folate receptor alpha staining, which is a protein that's often overexpressed in ovarian cancer, and when present is a biomarker for the drug mirvetuximab, which is used in recurrent ovarian cancer. So in conclusion, biomarkers, either genetic or otherwise, offer critical information to help your oncologist treat your cancer. In addition, if genetic risk is identified, this can have very important implications for your family members. And we have highly effective both early detection, screening, and surgical prevention options for family members who have those inherited mutations that predispose to breast and ovarian cancer. So I'm now happy to answer questions.
Okay. Excellent. So we are going to start with some Q&A. Thank you so much, Dr. Norquist. That was wonderful. And we'll jump right in. We've gotten a lot of questions in live in the chat, and a lot of people submitted questions in advance as well. So it's great. So our first question for you, does someone with ovarian or gynecologic cancer automatically get genetic testing and biomarker testing?
That's a great question. It's worthwhile to ask because this can vary depending on where you're being treated. And there are some programs that try to automatically order that, but I would not expect that to be a given. So I would definitely inquire with your medical team.
Okay, great. Next question, how can I find out if I have been tested and if I was tested for everything that I need to be tested for?
That's a great question. One method, like if you have a copy of the report, that can often be a critical thing to sort of save in your files. And one of the biggest problems with our current medical record system is it's really difficult to get the outside genetic testing really uploaded into a reliable place in the medical record. So that can be a challenge for both your doctor and yourself. But genetic counselors are kind of the ultimate sleuths in figuring this out. So if you think you had testing, like they can often track down a copy of your report from the company, even if you or your doctor don't have it, and they can help you figure out if additional testing would be beneficial to you.
Okay, got it. Now, and if you are unsure and you don't know how to get in touch with a genetic counselor, should people just ask their doctor? What would you recommend in that case?
Yeah, that's a great idea. So I think just going back to your oncologist, they should know how to connect you with a genetic counselor or how to help track down those results.
Okay, great. Thank you. Next question. I've had genetic testing and am BRCA1 mutation positive. How do I use this information to seek out clinical trials that are unique to my genetic makeup?
Yeah. So there's a few websites that will kind of list clinical trial eligibility. You can start with your medical team first to see if they have clinical trials available. There is clinicaltrials.gov, which lists trials. I imagine OCRA might as well let
We do, yes, thank you.
comment on that.
Yep.
And also the Force website also has a large section of clinical trials related to genetic mutations.
Okay, great. And yes, that's right. We have a wonderful clinical trials finder on our website. You can do it all online if that's easiest for you, or there's also a number you can call and speak to someone and they will lead you through the process. But that's great. Thank you for all those resources. Okay, next question. I have ovarian cancer, but no genetic mutations. Should my daughters be tested for genetic mutations?
Yeah, that's a really great question. So it depends on if their father's family also has any cancers in the family. If the person with ovarian cancer has had a comprehensive test and doesn't carry anything, then the odds of finding something in your children would be extremely low because it can't skip you to get to them. Um, but if their father's side of the family has cancers that could be inherited, then it may still be important for them to get testing to rule out a contribution from the other side of the family. But otherwise, we typically don't recommend that kids get tested if the affected person has had a comprehensive test.
Okay, thank you. How do I determine which biomarker test to get? Can I order them myself, or do they need to be ordered by my medical team?
Yes. So I think, again, going back to your medical team is the best way to figure this out. Um, if there are, specific things that you're interested in, I think bringing that up with your oncologist, they can really help to facilitate ordering that. There's perhaps some companies where you can directly request to order things yourself, but it's typically best accomplished through your oncology team.
Okay, great. Is it possible for a genetic profile to change due to epigenetics?
Yeah, good question. So, we do know that there can be changes in methylation between primary and recurrent cancers. So that could be something that would change. There's not a lot of assays that look for that. It's mostly being done in a research setting at this point, but that could become more important as time goes on.
Okay. Now, we've gotten a whole bunch of questions in about variations of unknown or uncertain significance. I'm wondering if you can just talk about these a little bit and suggest how people should proceed if they've gotten one of these results on their genetic testing report.
Yes, thank you so much. I was realizing as I was watching that video, I should have had a couple slides about variants of uncertain significance. So I'll try to make up for that right now and just a
Thank
quick
you.
ad lib. But variants of uncertain significance are essentially changes in the genome that don't. I'll back up for a second and say that there are certain types of mutations that are damaging to the ultimate protein that they make. And mutations that lead to a short protein or that remove a critical portion of the protein, those are the kinds of mutations that we know can cause disease. And variation in the genome is incredibly common. Every person has variations from whatever has been determined to be kind of the standard sequence. Variants of uncertain significance are just that. They're usually like a single change in the genome that may not affect the protein at all. And unless it's been around for a long time or we've had a chance to study multiple families with it, it's hard to know if that's something that can cause disease. There are various prediction models that try to look at the protein structure to see, okay, is that a really critical little spot in this, 1,000 amino acid protein? Or is that likely in a location that wouldn't make any difference? And so when it's a lesser studied gene or just a mutation that hasn't been seen before in the literature, that's sort of what ends up being called a variant of uncertain significance. And these are incredibly common. There is a possibility for them to get reclassified as time goes on. The vast majority of variants of uncertain significance get reclassified to a benign finding rather than a disease-causing finding. And the recommendation from genetic counselors and various professional societies is to not use a variant of uncertain significance for clinical care. We don't recommend testing family members for variants of uncertain significance, and we don't recommend targeting therapies to variants of uncertain significance.
Thank you. That's very helpful. Follow-up question. If VUS is reclassified as pathogenic, is that information that would be communicated to a patient in some way by her doctor or by her genetic counselor? How does that work? Is that something that patients need to monitor themselves?
Most of the genetic testing companies have some mechanism by which they reach out to people if a variant has been reclassified. But if you are a person that has a VUS, it's also, potentially beneficial to just check in with a genetic counselor every few years or so, or even every 5 years, just to say, okay, is there anything new about this variant? Has it been reclassified? There's also a research study called findmyvariant.com, where people who have variants of uncertain significance can kind of upload their information to sort of crowdsource additional family history and other features of other people who have those variants. That's a study run out of University of Washington. But typically the company is supposed to have some mechanism by which they notify you.
Got it. Okay. Next question. If you are BRCA1 positive, but it's a mutation created in the tumor itself, do your kids need to get tested too?
That's a great question. So I think just making sure that it's not, if the person has only had tumor testing, then it's not clear if it's inherited or from the tumor. And so in that case, I would recommend that the person with the tumor also have germline testing. But if they've had germline testing that's normal and just the tumor has the mutation, then their children cannot inherit that.
Right. Okay, great. Thanks. So here's one for you. What can a patient do if their medical and surgical oncologist refuse to allow the patient to participate in biomarker testing, like Signatera or whatever else is available, because they don't feel biomarker testing will change the way they practice treatment at all, or unless the cancer spreads? What to do? Is it too late then?
Could you repeat just the first part of that question? I'm so sorry.
Sure. What can a patient do if their clinical team basically refuses to allow the patient to participate in biomarker testing? And she said specifically like Signatera test or whatever else is available, because they don't fear that they don't feel like it'll change the way they practice.
Yes. No, that's a great question too, because in some cases, the technology and the kind of commercial test availability sometimes outpaces our knowledge of what to do with it. And so that can be a tricky position for your oncologist to be in. And if we truly think that the test is expensive and unlikely to help you, then one can feel morally conflicted about ordering such a test.
Okay.
So it can be challenging, but definitely worth just an open and honest conversation with them to make sure that everyone's on the same page.
Right. Okay. Should biomarker testing of the tumor be done at the time of debulking, or wait until the cancer comes back as documented on a CT scan and a rise in CA-125?
Yeah, so the NCCN guidelines and most of the major societies have all recommended that part of the initial workup be a test of the tumor and the germline. And part of this is because of the success with PARP inhibitors, because if the tumor had a BRCA mutation, you would want to know that up front, because then you would be a candidate for PARP inhibitor maintenance after primary treatment.
Okay, great. Would most insurance pay for the whole list of biomarkers in the guidelines without proof of the cancer returning?
Typically, just the diagnosis of the initial cancer is what's used to justify the testing. So you, of course, have to check with your individual carriers, because every group is different. But because it's recommended by so many societies, most insurances will cover a germline test and a tumor test. But again, you have to check with the individual carriers.
And related, kind of related, about health insurance, can results from testing affect my health insurance costs?
Yeah, they're not supposed to, is the short answer. The Genetic Information Non-Discrimination Act, or GINA as it's commonly known, has is a law that prevents discrimination against patients with genetic mutations in terms of their health insurance. But again, there can always be things that slip through.
My mom has ovarian and uterine cancer. After her surgery, her tumors were sent for genetic testing. All of her markers came back negative, but are my siblings and I still at risk?
So in those cases where there's an ovarian cancer in the family and the genetic testing is negative, it can be really tricky to know if the relatives are just at the population risk or could they be at some increased risk. It's thought that having one first-degree relative with ovarian cancer might increase your risk a little bit, somewhere on the order of 4 to 5%. At the most, and that data was calculated kind of before we had these comprehensive genetic tests. So it's hard for us to know what to do in that circumstance. But in that case, we typically look at the age of the individual who's concerned. We look at the entire family history to see if there are other ovarian or breast or pancreatic or other cancers that look like they could be part of hereditary breast and ovarian cancer syndrome. Because there are some families where we get concerned that there's something going on in the family, but we can't quite pinpoint what it is. And then it can be difficult to either include or exclude risk in family members. But typically with one family member with ovarian cancer that's had a negative test, then the most likely scenario is that that's a sporadic cancer and not an inherited cancer. But there are often things that children can do to help prevent ovarian cancer in the future.
Great, thank you. Okay, and believe it or not, this is our last question. Question is, I'm a recurrent ovarian cancer survivor and my brother survived prostate cancer, but neither one of us has a BRCA gene. Are you aware of any other genetic connections between the two diseases?
Yeah, there's more and more being discovered about kind of detecting mutations that may not come up on standard sequencing. And so there are some clinical trials and research groups that are looking for these connections. And so it's not impossible that there's something inherited going on, but these could also just be sporadic cancers as well.
Got it. All right, that's it. Thank you so much, Dr. Norquist, for a terrific presentation, very informative Q&A, and we really appreciate all of your time today. So thank you.
Thanks so much for having me.
Thanks. And moving right along, next up, we will hear from Dr. Ying Liu, who will give a presentation on the impact of genetic mutations and biomarkers on treatment decisions. Dr. Liu is an assistant attending at Memorial Sloan Kettering Cancer Center in New York, with dual appointments in gynecologic medical oncology and clinical genetics. She specializes in caring for women with gynecologic cancers and has a special interest in inherited cancers and provides counseling and genetic testing for patients with all different types of cancers. So we'll get started with Dr. Liu now, and then we'll take your questions.
Hi everyone, I'm Ying Liu. I'm a GYN medical oncologist here at Memorial Sloan Kettering Cancer Center in New York City, where I lead our inherited GYN cancer program and have a special interest in cancer genetics. I'm so excited to be talking to you all today. I know Dr. Norquist has done a wonderful job of giving the basics of genetics, genetic testing, and biomarkers, and I'm really excited to take a deeper dive into how these genetic findings and biomarkers influence our treatment decisions for our patients with ovarian cancer. So let's go ahead and get started. So how do we treat patients with ovarian cancer, and why does genetic testing matter? Well, unfortunately, most of our patients are diagnosed with pretty advanced stage 3 or 4 disease. And because of this, the treatments are very intense, and most of our patients undergo surgery as well as platinum-based chemotherapy. This can happen in one of two ways. It can happen with the chemotherapy first, followed by surgery, and then more chemotherapy in a sandwich style. This is what we call the neoadjuvant approach. or it can happen with surgery first, followed by platinum-based chemotherapy. And this is the primary debulking approach. And we've had many studies showing us that both approaches are equally as good. But the goal of these treatments is really to get our women into remission with as little visible cancer as possible and to try to keep them there. Unfortunately, ovarian cancer is a very tough disease, and despite our best efforts, 80 to 90% of women will have a recurrence of their cancer. And so we're always trying to do better here. And this is the area of treatment where genetic testing and biomarkers really matters in helping us make the best treatment decisions for our patients. Now, when I talk about ovarian cancer, what I mean are both fallopian tube and primary peritoneal cancers. We kind of include all of this in ovarian cancer. And when we talk about the ovaries, we're really talking about that lining, the epithelial space. And these are really epithelial ovarian cancers, or cancers coming from that lining. And specifically, we know that there are many, many different types of ovarian cancer, but the most common one, and the one we mostly talk about, are the high-grade ones, specifically high-grade serous ovarian cancer. Now, we've heard a lot about the importance of genetic testing for ovarian cancer, and it's been universally recommended by several organizations, including the Ovarian Cancer Research Alliance. And we heard a lot already from Dr. Norquist about the importance of genetic testing for ovarian cancer prevention. But today I want to convince you that it's also important for ovarian cancer treatment. Now, from all of our patients with ovarian cancer who have had genetic testing of what we call the germline, or the inherited portion, we know that about 15 to 20% of women are going to have a germline mutation or a change in their DNA that they were born with that increase the risk of ovarian cancer. Another way of thinking about this is by saying that 15 to 20% of ovarian cancer is inherited, runs in families. And when we look at the different genes involved, the ones we most commonly see are BRCA1 and BRCA2, but there's some other ones as well, which we'll talk about. Now, what are BRCA1 and 2? Well, these are important genes that make proteins that are involved in a specific way that the cell repairs DNA, called homologous recombination, or HR. Now, these genes and proteins, they work with other proteins that you may have heard of, like PALB2, RAD51, and together they help repair damage that occurs to both strands of the DNA. And this is a really, really important way that the cell repairs mistakes that happen. And so when you have a mutation or change in these genes, these proteins don't work properly and they can't repair the DNA. And when that happens, these mistakes or mutations, they accumulate and they accumulate until you hit a breaking point and the cell morphs into cancer or the cell dies. And that's why having a mutation in these genes increases your risk of cancer. But can we take advantage of this when we're thinking about cancer treatments? And can we use these markers, BRCA1 and 2, and this homologous recombination, or HR deficiency, HRD, as biomarkers? Now, it's also important to remember that it's a universal recommendation to do genetic testing inside of the ovarian cancer tumor as well. And what we've learned from doing this is that about 50% or a half of ovarian cancer tumors have this HRD, or homologous recombination deficiency. Half of the half, or 25% total, is due to an inherited reason, or a germline change, most commonly in BRCA1 or 2, but also other genes. And then the other half of the half, the other 25%, is due to something that happens in the tumor. So it's not something that's inherited, it doesn't run in the family, but it still happens in the tumor and gives the tumor this HRD biomarker, and that's important to remember. Now, we know from historical studies that BRCA1 and 2 are important biomarkers. They're both prognostic, meaning they tell us about the prognosis of women with ovarian cancer, and predictive. They tell us how well women with this type of ovarian cancer are going to respond to chemotherapy. So I have on the slide 3 graphs, and these are what we call Kaplan-Meier survival curves. I'm going to walk you through it because we're going to see a couple of these later as well. And essentially what these curves measure are how well our women are living without cancer over time. And so on the x-axis, as you go from left to right, you see time in months. The y-axis tells you, how many women are still alive, how many women are in remission, and you want to be close to the top because the top is that 100%. And as time goes on, you see some women do have their cancer coming back, and some women unfortunately pass away. But what you see here are that the curves in pink and blue seem to be higher and doing better than the curves in black. And that's because the curves in pink and blue are the ones associated with BRCA1 and 2. And here you're seeing that these women are living longer. That's the first figure. They're staying in remission for longer. That's the second one. And they're responding better, having longer remissions after platinum-based chemotherapy. That's that third curve. And so that's how we knew that BRCA1 and 2 were important biomarkers for both prognosis and response to treatment. But what about newer treatments like targeted therapies? What about these PARP inhibitors that I'm sure we've all heard about? Well, I've highlighted here the 3 PARP inhibitors that are currently FDA approved for ovarian cancer. We have olaparib, niraparib, and rucaparib. The way a PARP inhibitor works is through a process called synthetic lethality. So PARP inhibits another pathway, another way that the cell uses to repair DNA. This time it's the way it repairs damage in only one strand of the DNA. And so when you block PARP with a PARP inhibitor, the cell can't repair its DNA through that one pathway. This is really important because I told you earlier that cells that have mutations in BRCA1 or 2 or have this HR deficiency also have trouble repairing their DNA through this other pathway called HR. And so when you block both of them, that's where you get that combination effect, that synthetic lethality that leads to even more mutations and hopefully cell death in these cancer cells. And that's why we think these PARP inhibitors work better in ovarian cancers and other cancers associated with these BRCA1 and 2 mutations, as well as this HRD biomarker. So we thought this scientifically, but did we see this when we tested it in women in clinical trials? And the answer is yes. And so one of these trials, which is really critical, is something called SOLO-1. In this study, we looked at women with newly diagnosed ovarian cancers. Importantly, all of these women had BRCA1 or 2 mutations. Either they were born with them or they had them inside the tumor. And all of these women had surgery and finished their chemotherapy. And then when they were done, they were randomized to a PARP inhibitor, this time olaparib, for maintenance therapy for either 2 years or they were randomized to a placebo. And then these women were monitored to see over time how many of them had a recurrence of their cancer and how many of them stayed alive. And so what we found was that the women who received the PARP inhibitor were much more likely to stay in remission. Now this is another one of those Kaplan-Meier curves, and you can see right off there's a huge difference between the orange line, which is the olaparib group, compared to the blue line, which is placebo. And again, you want to be close to that top. And what you're seeing is that at 60 months, which is 5 years, 48% of the women in that olaparib group were still cancer-free, compared to only 21% in the placebo group. And we saw a huge reduction in the risk of recurrence, almost 70% in patients receiving olaparib compared to placebo. And when we looked at how often women were still alive after receiving this therapy, we saw a very clinically significant benefit. In other words, more women with olaparib were alive after 84 months than women who received placebo. Although this wasn't technically statistically significant, you can see there's still a pretty big difference between the two curves. And so we do think that there's a great benefit for these PARP inhibitors in patients with BRCA1 and 2 associated ovarian cancer. Now, what about all the other women with ovarian cancer who don't have these BRCA1 or 2 mutations? So this is another important study. It's called PALA-1. It's very similar to SOLO-1 that we just talked about, except this included all women with ovarian cancer, all different types. And again, they all had newly diagnosed cancer. They all had genetic testing, and they all had surgery and chemotherapy. And then when they were done, they were randomized again to either olaparib for 2 years as maintenance or placebo, but this time everybody got a different maintenance medicine, something called bevacizumab. And again, the investigators, they measured these women over time and measured how often they were still in remission and how many were still alive. And the one thing that they did here that was different from SOLO-1 is that they did more in-depth genetic testing for the biomarkers. They tested everyone for BRCA1 and 2, but they also tested for HRD. And they did this using a test called genomic instability score. And they did this through the Myriad MyChoice test, which is the FDA-approved companion diagnostic. And this test is what we call an indirect measure of the genomic scar within the tumor. And it really looks at 3 different components. It looks at something called LOH, which is loss of heterozygosity. It looks at something called TAI, or telomeric allelic imbalance. And then it looks at something called LST, which are large-scale state transitions. And it uses all of these things to calculate a score, a number, and they use a cutoff of 42. And if your score is higher than 42, the tumor is considered HRD positive, and if it's less than 42, it's considered HRD negative. And that's the biomarker they used for this trial. Now, this test has limitations. You know, it is not a dynamic measure. It's not something that you measure over time. It's static, so you just measure it once at the beginning. And we know that the score is continuous. We think that if your score is higher, you have more of this HRD-ness in the tumor. And we know that there are other tests out there that measure this, and sometimes there's variability. And so that's something that needs to be accounted for, but specifically this trial used this test. And what we saw was that both HRD and BRCA1 and 2 were really important biomarkers, and they helped us decide which women with ovarian cancer benefited more from the PARP inhibitor. So these are 3 Kaplan-Meier survival curves, and you can see that they're different. The first one includes all of the patients with HRD tumors, including the ones with BRCA1 and 2 mutations. And here you see the biggest difference between the red and the blue. The red group being the olaparib group and the blue group being placebo. And you can see that in this group, the benefit from the PARP inhibitor maintenance was the biggest. Now the figure in the middle shows you that HRD group without the BRCA1 and 2 patients. And what you see there is still a benefit. You still see a difference between the 2 curves, but it's not quite as big as that first one on the left. And then the figure on the right shows you the HRD proficient group, or the ones that don't have an HRD phenotype in the tumor, tested negative. And what you see here is really no difference between the curves. And you see that in this group, there was very little benefit to the olaparib maintenance. And this is important because these are important biomarkers that can give us a clue into how much these PARP inhibitors could help a woman with ovarian cancer. And we need to know this because these PARP inhibitors have side effects. They all cause fatigue, they all cause nausea and other GI side effects, but they can also affect the blood counts. They can cause anemia, which is lowering of the hemoglobin, and sometimes women need transfusions. They can cause thrombocytopenia, which is lowering of the platelets, and sometimes this can be very severe and put women at risk for bleeding. And very, very rarely, they can cause a very serious side effect, what we call a secondary or treatment-related MDS or leukemia, which is a very serious blood cancer. Although the rates of this are very, very low, it is a very big deal. And that's why when we're making decisions about PARP inhibitor therapy, we have to balance all of these things. We have to balance the potential benefit to our patients. And this involves using genetic testing and the genetic biomarkers we talked about, BRCA1 and 2, as well as HRD status. But we also have to balance that with the side effects, the toxicities of these medicines, and the overall risk of MDS and leukemia. Now, because these medicines, these PARP inhibitors, are doing so well for our patients with BRCA1 and 2 and HRD positive ovarian cancer, there's a question of, well, can we de-escalate? Can we reduce the duration of treatment and maybe reduce some of these side effects? And we are going to be asking this important question in a phase 3 trial, NRG GY036, that's going to test 2 versus 1 year of olaparib maintenance with or without bevacizumab in BRCA1 and 2 and HRD positive ovarian cancer after surgery and chemotherapy. So this trial is hopefully going to open in the coming months, so keep an eye out for it. Now, what about the other half of ovarian cancers, the other 50% that don't have BRCA1 and 2 mutations and don't have HRD? What do we do for these patients? Well, we desperately need biomarkers in this space to help tailor our therapies. And I think one of the most promising biomarkers in this space is something called CCNE1. And it's specifically looking at amplifications in this gene, meaning it has more copies than it should. And the reason this gene is important is because CCNE1 is involved in the cell cycle, so cell growth and division. And when you have too many copies, this process goes awry and you get crazy growth that can lead to very aggressive cancers. And so there's several different drugs in clinical trials that are targeting various areas in this pathway. So you may have heard of CDK2 inhibitors, WEE1 inhibitors, PKMYT1 inhibitors, ATR inhibitors. These are all examples of drugs that are being tested in clinical trials, either on their own or in combination with chemotherapy for tumors that specifically have this biomarker of CCNE1 amplifications. What about immune therapies? My patients are always asking me about immune checkpoint inhibitors. They see it on TV and commercials. They see it being used for their friends with lung cancer, melanoma. They're always asking me, why aren't we using these drugs in ovarian cancer? And I tell them these are very good medicines. You know, they work where your immune cell interacts with the tumor cell, and they help to facilitate those interactions so that you get a stronger immune response and your immune system is better able to find the cancer. But unfortunately, even after testing these medicines in ovarian cancer, we just haven't seen a lot of success. In fact, they're really only effective in a very small subset of ovarian cancers with very specific biomarkers. And these include things like high microsatellite instability, something called MSI high, or mismatch repair deficiency, or MMRD. The other time we sometimes use this is if tumors have a biomarker called high tumor mutational burden, or TMB, and this is usually defined as having 10 or more mutations per base pair. And these are biomarkers that have shown benefit for these immune checkpoint inhibitor irregardless of the type of tumor, and there are FDA approvals specifically for these biomarkers. So what exactly is high microsatellite instability and mismatch repair deficiency? Well, it's when you have mutations in proteins that specifically repair the DNA through this mismatch repair pathway. And when this pathway is mutated or altered, you get a very specific pattern of mistakes in the DNA. They happen in these very large regions where the DNA repeats itself called microsatellites. And that creates a DNA signature that looks very different and creates a very strong antigen that stimulates the immune response. And interestingly, we actually first discovered this in relation to Lynch syndrome, which is another inherited cancer predisposition syndrome where you see a lot of colon cancer and uterine cancer and also some rare endometriosis associated types of ovarian cancer. Now, these immune therapies do also have side effects. They're different from chemo, and they're more related to the immune system being overactivated. And you can see inflammation in the body in various areas. You can see rash, you can see joint pain, you can see inflammation in endocrine organs like the thyroid, you can see inflammation in the gut, which presents with diarrhea or colitis, you can see inflammation in the liver. Very rarely this can happen in the lungs, in the heart. So, you know, there still are side effects. They're just a little bit different than regular chemotherapy. And I don't want anyone to think that there's nothing promising related to immune therapies for ovarian cancer. There definitely is. There's a lot of interest in these new adoptive T cell therapies, what we call CAR T cells, which you may have heard of in the news. And there's a lot of fancy cars these days. So I put up this picture of a very fancy car, and there's a lot of clinical trials looking at this. But I think one of the most promising therapies for ovarian cancer that we've recently found are really these antibody drug conjugates, or ADCs. And what these are antibodies that target a specific marker in the cell, and they're linked to chemotherapy. And what I tell my patients is these are targeted missiles. So they hone in on a marker in your cell, and they go there and they bring a payload of chemotherapy and they drop it directly into the cell. And the thought is that this leads to better killing of the cancer cells and hopefully less side effects, or at least different side effects. And what we've seen recently is the approval of this medicine, mirvetuximab soravtansine, which we call MIRV for short. And this is the first ADC that's been FDA approved for the treatment of platinum-resistant ovarian cancer. And the biomarker that it targets is something called folate receptor alpha. And you need pretty high expression. So the picture I'm showing you on the left, it has a lot of that dark brown. That means there's really high expression of this folate receptor alpha. Whereas the panel next to it, there's a lot more pink and a lot less brown, and that means there's less expression. So if your tumor looks like that, you may not be eligible for this therapy. Because what happens is this antibody drug conjugate, it binds that folate receptor on the tumor, and it gets internalized into the cancer cell, where it then releases the chemotherapy inside the cell to kill the cancer cell. And when the cell dies, some of that chemo gets to the surrounding cells, and that's how these ADCs work. Now, there's a lot of trials where we tested MIRV, but one of the most important is a trial called Mirasol. And this is where mirvetuximab was compared to standard chemotherapy in patients with high folate receptor expressing platinum-resistant ovarian cancer. And basically, the investigators measured how well women with ovarian cancer did with these treatments and how well they shrank and controlled the tumors. This is another one of those Kaplan-Meier survival curves, and we see that the patients receiving MIRV, which is the orange line, did better than the patients receiving standard chemotherapy, which is the blue line. This is a different type of graph. This is something called a waterfall plot, and this is how we see the amount of tumor shrinkage with a medicine. And we call this a waterfall because we want to see those bars go down. We want to see a big waterfall. That shows us that the drug is working well and really shrinking the tumors. And you can see that the MIRV, the patients receiving MIRV, which are the orange bars, have a much bigger waterfall. More patients had shrinkage of their tumors than the patients receiving standard chemotherapy, which are the blue bars. Now, there are a lot of very promising ADCs being studied in ovarian cancer, and they're targeting lots of different biomarkers. We have other newer generation ADCs looking at targeting folate receptor alpha. We have ADCs looking to target mesothelin, tissue factor, MUC16, TROP2, NaBi2b. These are all various biomarkers and trials that are currently open. But I would say one of the most promising ADCs is something called trastuzumab deruxtecan, or TDXD, which targets a biomarker called HER2. This was originally tested in breast cancer with amazing results, and now they've tested it in various different types of tumors that have high HER2 expression. And I circled here in red the ovarian cancer group, and you can see that there was a lot of efficacy, a lot of tumor shrinkage in those tumors that expressed high levels of HER2. And now there are FDA approvals and NCCN recommendations to consider this medicine in ovarian cancers that have high HER2 expression. Now, these ADCs are chemotherapy, so they do have side effects, and I tell my patients they have similar side effects to chemotherapy. So you do have side effects for the blood counts, lowering of the blood counts, infection risk, you have nausea, diarrhea, you can get neuropathy, but But side effects that we see specific to these ADCs include side effects in the eyes. So sometimes you have to see the eye doctor, you have to use special eye drops, and then very rarely you can have toxicity in the lung, and specifically this pneumonitis or inflammation. And then some of these ADCs, specifically TDXD, can cause side effects in the heart and lead to reduced heart function. So that needs to be monitored as well. And these side effects need to be carefully assessed. But in general, genetics and biomarkers are becoming incredibly important for ovarian cancer treatment, and that again just underlays and underscores the importance of genetic testing for all patients with ovarian cancer so that they have access to these new targeted therapies. And so hopefully today I've shown you that there's a lot of hope for treatments in ovarian cancer, and that the more genetic testing we can do, the more biomarkers we can develop. So thank you all so much for your time.
Okay, wonderful. That was a great presentation. Thank you so much, Dr. Liu. And again, reminder, everybody, you can pop your questions into the Q&A, and we will have some questions with Dr. Liu. There she is. Hi, Dr. Liu, how are you?
Hi, Sarah. I'm good. I'm good. So excited to be here today.
Thank you so much for joining us. It was a great presentation. You made very complicated topic very easy to understand, and I really appreciate that. It was great. So we're going to jump in. We are going to start with a whole lot of questions about PARP inhibitors, which is probably no big surprise. But there are a lot of great questions. So a bunch of the questions focus around duration of use for PARP inhibitors, and you sort of touched on this as an open question. Just wondering if you would talk a little bit more about it. People are wondering, this person specifically asked about Lynparza, but I think in general, right now, are these intended for long-term use? How long should we be on it? What's the typical length of time? If you could just sort of talk a little bit about that, that'd be great.
Yeah, this is a great question. And I think everyone is sort of hitting on the uncertainty in the air, the changes in a lot of the FDA approvals for PARP inhibitors, how we're using PARP inhibitors, data, long-term data from these studies, looking at more of the long-term side effects. And so, these PARP inhibitors were originally tested in patients with recurrent ovarian cancer. And at the time, we knew that they were promising, but we didn't know how promising or how well they would work. And traditionally, clinical trials run in that setting are kind of meant to have indefinite treatment until either the treatment didn't work or there was a really bad side effect and someone has to stop the treatment. So it was actually surprising that the PARP inhibitors worked so well. And in some of these older studies, women were on them for a long time, even over 5 years. And as we started to use these PARP inhibitors in more newly diagnosed patients, we were starting to see them have long-term remissions. And, in the newly diagnosed space, you don't want women to be on treatment indefinitely. So a lot of the trials I talked about, like SOLO-1, PALO-1, had a discrete amount of treatment. So kind of 2 years was picked for those two trials, but there were other trials that used longer durations, like 3 years. And at the same time, we were getting more and more data from the older studies showing that women who are on PARP inhibitors for a long time had more toxicity. So there were higher rates of the blood cancers, the MDS and leukemia that I talked about, that are very deadly, and that we were seeing women who went on to get other treatments maybe not receiving as much benefit because they'd been on the PARP inhibitor for longer. That was one of the hypotheses. So one of the shifts has been to try to find the right balance between how long you need the PARP inhibitor for benefit, for cancer control, and balancing that with the long-term side effects. And so, that's actually why we developed NRG GY036, because it's working so well in this subgroup of patients with BRCA1 and 2 mutations and HRD positive tumors. can we spare them some of the toxicity? Can we get away with just 1 year? And is that just as good as 2 years? And will it reduce some of the long-term toxicities? And then just like Louise said, patients who are on these pills, it's not easy. There are definite side effects. And even if they're not so severe that you have to stop them, my patients say they definitely notice a difference, especially in their appetite. They just feel, one of my ladies just says, I just feel icky. I can't describe it. I just feel icky. And when they come off, they notice a difference. So I think the general trend with using PARP inhibitors these days is to use the biomarkers to inform who is going to have the most benefit and to really have a conversation about risks and benefits and to try to use them in the frontline setting and to try to understand if less could be more.
Thank you. That's very helpful. And related question, but this is specifically about lower doses. We've got some questions related to side effects and if lowering dose of the PARP will help, but then related concerns about potentially decreased efficacy on a lower dose. Is there any data on that?
Yeah, so in the trials, most of the women had to have breaks and had to have the doses reduced. In fact, one of the PARP inhibitors, niraparib, actually had adjustments in their dosing based on tolerability. And later on, they tested a different dose that was a reduced dose based on a patient's weight and their platelet count. And so what I tell my patients is that we start at the full prescribing dose and we do our best. And if you're having a hard time, then we take a break and we try a lower dose because 2 years is a long time, or however long you're deciding with your oncologist that you're going to try to take these medicines, and something is better than nothing. So whatever we can do to help get you through this, and if that includes taking a break around travel plans or important occasions, if that includes reducing the dose, whatever can help you stay on the medicine for as long as possible for whatever you're aiming for.
Great. Okay, thank you. We have a question about the use of PARP inhibitors potentially reducing the risk of other cancers for which BRCA mutations also cause an elevated risk. Can you comment on that?
Absolutely. This is a question we get a lot because we know that the same mutations that increase the risk for ovarian cancer, like BRCA1 and 2, also increase risk for breast cancer, pancreatic cancer, prostate cancer. I think, Helen's story and her family really showed us this. And in those cancers, PARP inhibitors are also approved to be used as treatment in the subset of those cancers related to BRCA1 and 2. We know a little bit less about other genes like PALB2 and ATM and things like that may also be related to breast cancer and prostate cancer. But certainly in BRCA1 and 2, there's thought that it may be helpful. I don't. We don't have a lot of clinical trials. We don't have a lot of data showing this just yet. There are trials looking at this. And in general, rates of breast cancer after ovarian cancer are low. And because a lot of the times the treatment for ovarian cancer is very intense and just the overall mortality of ovarian cancers is different than breast cancer. But it's an interesting question. And I think the long-winded answer is it's scientifically very interesting. I understand why people would ask that, but we just don't know. And you have to balance the risk also of taking these medicines for a long time.
Right. Okay, thank you. New question. How does an unusually high HRD score impact treatment options and prognosis, or does it?
Yeah. So when I talked a little bit about the GIS score and in how these HRD tests are used, for simplicity, it's a cutoff and they give you a yes or no. And if your tumor is HRD, then you would qualify for PARP inhibitor maintenance and theoretically would have benefit. There have been some studies, including from our own center, showing that higher scores may mean that you're going to get more benefit. But like I said, and Dr. Norquist said, none of these biomarker tests are perfect. We're still trying to figure out the best ways of of measuring HRD. So, a score of, let's say, 200 on one test may mean something different than a different score on another test. And just keep in mind, these studies were used with the FDA-approved companion diagnostic, but the test that your oncologist may use may be a little bit different.
Right. Okay, thank you. Next question is, why are PARPs only offered to advanced stage ovarian cancer patients? This person was diagnosed as stage 1 and is wondering if PARPs would be available to her in the future.
Yeah. My patients ask me this a lot as well. So the studies that we did were mostly in advanced stage, so stage 3 and 4, and that's because the majority of women are unfortunately diagnosed with advanced stage. In stage 1 and 2, it's just more rare, and the risk of the cancer coming back after surgery and chemotherapy, if you need chemotherapy, is lower. So it's really a risk benefit assessment, right? Is the potential risk from the PARP inhibitor, the side effects, the long-term risk of the secondary MDS and leukemia, is it worth it if your risk of the cancer coming back is low? And for stage 2, we do think that it may be. And so for patients with stage 2 ovarian cancer, I have this conversation. The NCCN recommendations do discuss potentially using PARP inhibitor maintenance in this space, even though these patients weren't included in the original studies. For stage 1, it's a lot harder. Stage 1 is very rare, and the thought is that because those patients, will do well, the risk of recurrence is lower. The risk of the PARP inhibitors just may not be worth it. But I think that needs to be an individualized discussion because everyone's situation obviously is a little different.
Great. Thank you. So in your presentation, you mentioned folate receptor alpha. We have a question. If I had biomarker testing, can I assume that I was tested for folate receptor alpha?
Yeah, no, the short answer is no. I tell my patients, don't assume anything, look at the fine print. Just like Dr. Norquist said, most tests will tell you what they test for, but it can be hard to find that. And so I think the best thing to do is to bring the report in to your oncologist. They will tell you sort of what genes are tested, what biomarkers are tested, what your tumor was stained for, but there's variability in what each commercial test does or in how your oncologist may order this. And because folate receptor alpha testing is relatively new in the last few years, if your genetic testing or biomarker testing of the tumor was performed many years ago, it may not have been included. So you may need updated testing for that.
Okay, thank you. Are there any new or emerging biomarkers beyond CA125 and HRD that are being researched for ovarian cancer monitoring or predicting recurrence?
This is another good question, and I think Dr. Norquist got a similar question about sort of monitoring circulating tumor DNA. It's both a practical and a philosophical question, right? So the practical part is, do we have the technologies to detect different components of the tumor, be it tumor DNA that's in the blood at very, very low levels before you start to see tumor cells on a CAT scan or before CA125 starts to go up, right? So there are definitely lots of tests looking into this, and the technologies are improving, and this is being done in other cancer types. But the philosophical question is, well, just because we can do it, should we, and does it offer benefit, right? So I think anytime I order a test, I ask my patients, well, what are we going to do with the answer? And is it going to affect our treatment? And if the answer is no, then we really have to think about if we want to do the test. We've had data and studies showing us that maybe initiating treatment early based on CA125 rising alone without evidence of cancer in a CAT scan may not be beneficial in the long run. And right now we're studying this, but we don't really know what initiating treatment early based on, say, circulating tumor DNA or some other biomarker, what that would do for the long term. And I tell my patients often, I'm thinking about this as a marathon. I'm sort of thinking about this long term, and sort of when to use certain biomarkers and when to use certain therapies. So I think there's a lot of promise in these sort of early detection tests, but we're still learning how to use them. And that's in patients with ovarian cancer. I think probably the other aspect where this is really important, and there's a lot of research, is in patients at high genetic risk for ovarian cancer. Are we developing better screening tests, right? Because our historical screening tests, CA-125, transvaginal ultrasounds, and other things have not been very effective. And are these new biomarkers potentially going to be effective in that space? So it's a little bit of a different scenario than patients with ovarian cancer who are undergoing treatment, but definitely a lot of studies there, and hopefully a lot of promise as well.
Okay, thanks. A question about Keytruda. Is Keytruda a good preventative maintenance treatment for ovarian and endometrial cancers?
Okay, it's a lot in that question. All right, I'll
Yes.
take it. I'll take it one step at a time. So I think we have to separate ovarian and endometrial cancer here. So Keytruda or pembrolizumab is one of those immune checkpoint inhibitors. It's a very good medicine. It's approved in a lot of different cancer types. Unfortunately, it hasn't shown a lot of efficacy in ovarian cancer. So unless your ovarian cancer is one of those special types that has high MSI or mismatch repair deficiency or a high tumor mutational burden, it hasn't really been shown to be effective. And just like I said in the presentation, there are very real side effects that can be serious from these immune checkpoint inhibitors. So in ovarian cancer, there's really limited use. Endometrial cancer is a whole different ballgame, and I think we could spend a whole session on just endometrial cancer. There have been a lot of new studies lately showing the promise of immune checkpoint inhibitors like pembrolizumab in endometrial cancer, specifically the MSI high mismatch repair deficient group, which is about 30% of endometrial cancers. About 10% of that 30% is due to Lynch syndrome, which I know Kathy talked to us a little bit about, but a lot of them are actually not due to an inherited condition. It's due to something that happens in the tumor. So in that subset of endometrial cancer, there's profound benefit to adding these immune checkpoint inhibitors. In the mismatch repair proficient endometrial cancer group, there's been some new studies that show that maybe there's less benefit, and I think we're still sorting that out. And that, of course, has to be a discussion about the risks of immune-related side effects, because a lot of the studies looking at maintenance therapies have you taking these immune checkpoint inhibitors for 2 or 3 years.
Great, thank you. Okay, we've gotten so many great questions in. Unfortunately, we're running really short on time, so this will be the last question we have time for. And the question is, does the antibody drug conjugate treatment you discussed apply to low-grade serous ovarian cancer? Or I guess, general question, is it just high-grade serous?
It's another great question. So we didn't have time to dive into the different subtypes of ovarian cancer and sort of the more rare subtypes, but there's also been a lot of new studies and treatments in low-grade serous ovarian cancer. Because the genetic drivers in low-grade serous ovarian cancer are very different from high-grade serous ovarian cancer, it's been different types of therapy, but there are targeted therapies looking to inhibit those pathways, and there's a lot of promising pills and pill combinations. The antibody drug conjugates have not been studied as well in low-grade serous ovarian cancer, but one of my colleagues, Dr. Rachel Grisham, is one of the world's experts in low-grade serous ovarian cancer, and she actually did look at levels of folate receptor alpha staining in these tumors, and we were surprised that it was higher than we thought it would be. So I think as we're testing more patients and their tumors, and we start to test more rare subtypes, we may see that these rare subtypes also have high levels of some of these biomarkers, and those potentially could be targeted with these types of drugs going forward.
Okay, that's all we have time for, but thank you so much, Dr. Liu, for your great presentation and for answering so many questions. We really appreciate your time today. Thank you.
Thanks for having me.
My pleasure. Okay, and thank you all for joining us today and for your participation in this seminar. We hope the insights shared by our speakers have been helpful and informative. And our aim was to give you a clearer understanding of genetic and biomarker testing, as well as the latest developments in precision therapies. And I hope this information will support you or your loved ones in making informed decisions about treatment. And remember, OCRA, we're always here to provide ongoing support and resources. So if you missed any of this online seminar today, it will be on our website, which is ocrahope.org, later today. And if you have any further questions or need assistance, just feel free to reach out to us. And if you're interested in learning more, I want to invite you to join our online gynecologic cancer conference, which is next week, September 25th through 27th. You can learn more on our website at ocrahope.org/conference. So thanks again for being part of this important conversation. And another big thank you to our sponsor, AstraZeneca. We wish you all the best and look forward to staying connected.